I particularly want to acknowledge what Michael's been telling us over the course of the day. It really has been an absolutely comprehensive and in-depth review of the whole spectrum of medication error. We've looked at the factors that contribute to it. He spent some time looking at some really excellent examples of the actual medication errors that have occurred and how they've been addressed, and also given us some insight into the ISMP, the Canadian system, and how they do their work in regard of this area. And I particularly want to acknowledge that because the MERP program, the Medication Error Reporting Program, is really modelled on the ISMP. Way back in 2007, when we started thinking about putting together a medication error reporting program, ISMP Canada were immensely helpful and have continued to be tremendously supportive of the MERP and its development and some of the problems that we've had and the initiatives that we've thought about. So really what you're going to hear me talking about now about the MERP here in New Zealand is essentially the New Zealand version of where we've got to. As Michael said, this is early days for the New Zealand MERP. We've only been around since 2009, really. We started thinking about it in 2007. So, it's not an awful long time by comparison to ISMP Canada. But as I say, that's the gold standard. That's what we would like to aspire to. And certainly from what we've seen earlier today with Mike's presentations, we'd love to be fully involved in that way with the kind of staff complement that they have. So what I want to do here today is to talk about the Medication Error Reporting Program, and particularly focus on where it fits into pharmacovigilance in New Zealand. I'll give you a bit of an example, or more than a bit of an example, of how the MERP works, and then just finish off with some considerations about what the future is looking like and where we could be going and some of the issues that are facing us in that regard. Now, Michael in his last presentation began to address this issue of what is medication error and where does it fit in terms of adverse drug reactions. And this is just another depiction of the way in which we could consider this universe. So the green shading there are adverse drug reactions. These are the inherent properties of a medication, the toxic qualities of a medicine. And we, from an adverse drug reaction perspective, try to look at it simplistically and say those are the sort of type A, which are the dose-related adverse events, or the type B, which are not dose-related, the allergic type adverse events. Those are the ones that really cause the issues and concerns and problems and cause the injuries. So those are due to the properties of the medication. At the other end of the spectrum, the blue is referring to the medication error that occurs, and sometimes those don't result, or very often they don't result in significant issues for the individual, but they have the potential to do that, and if they do, they can actually cause harm. And so that overlap area is the area that we're really concerned about, to try and avoid those from happening. And certainly also to try and avoid the whole bunch of medication errors from occurring, because even though they don't cause harm, the Swiss cheese holes could align and they actually could end up causing harm. So our focus really at the moment is to look at that overlap area. So we heard earlier today that the whole issue of medication error has been a long-standing issue and a long-standing problem, and globally we've recognized, or it has been recognized, as an area that we should be focusing on because it causes significant harm. And as we heard, it's now the third global patient safety challenge due to the magnitude of the problem, and hopefully by addressing this issue in a coordinated and consistent way, we can bring about reductions in this harm. 50% is the target, but look, even if we can achieve anything, or anything more than we have at the moment, is a tremendous step forward. So I want to talk about where MERP fits into our pharmacovigilance setup here in New Zealand, and this diagram here is an attempt to try and put the various components into some sort of perspective. And I want to focus your attention on the blue part of this image, the blue box in the middle, which is the Pharmacovigilance Centre. And I've done this in every centre just to kind of get you moving a little bit as well. You move your hands and arms. Who has heard of the Pharmacovigilance Centre? Just the raise of hands would be great. Okay, that's really good. A good number of you do. And CALM, the Centre for Adverse Reaction, oh, even more. Okay, well, that's good. You didn't know about pharmacovigilance, but you knew about their great. And who sent a report to CALM? Still a good number. MERP, who's aware of MERP? Oh, I'm surprised. And who's actually put a report into MERP? Good show, less of you, but at least some of you are aware of it. Okay, so good. Those are the components of what our Pharmacovigilance Centre in Dunedin is all about. But what I want to just mention for a moment is just to talk a little bit about the infrastructure that we have here in New Zealand. And to do that, I need to mention the Centre for Adverse Reaction Monitoring. So that centre has been in Dunedin for now 52 years. It started in 1965. And for those of you who think back to the history of drug harm or drug safety, whichever way you want to look at it globally, that's hard on the heels of thalidomide, when countries were waking up and figuring out that we need to do something to reduce the time to identify those adverse events. And New Zealand was one of the first 7 or 8 countries to set up a program internationally. A small country at the back of beyond in global terms put this program together. It was put together by the then professor of pharmacology at the University of Otago. Today we would consider that person to be a clinical pharmacologist. The year before he had initiated or put together the National Poison Centre, so he was a bit of a visionary or entrepreneur of the day. And in those days that centre was funded through research funds, and it was an area of interest at the time. And reports were notified to the centre essentially as clinical consults, in the same way that you do clinical consults today. Name patient, there's a question that's raised, or at least alerting the issue so that a database could be populated with a view to ultimately doing something about it. And as you know, today, that sort of function is commonplace in pretty much everywhere in the world. Today there are over 125 countries that have got national adverse drug reaction monitoring services. Now, in pretty much every one of those 125 countries, that function is part of the regulator. In New Zealand here, it's actually the MedSafe's responsibility, in the same way that in the US it's the FDA, and in the UK it's the MHRA, for example. So New Zealand's a fairly unique arrangement because it's remained at the University of Otago in Dunedin. And that's probably because if it works, don't fix it. It actually works very well, and it does seem to have worked very well over time. And we believe continues to do so. For the first very many years it was funded through research funds, and probably in the last 30 years or so that arrangement has been formalized through a contract. So we have a responsibility in delivering those pharmacovigilance services to New Zealand on contract to the Ministry of Health. And obviously there are requirements in terms of that. MedSafe has a regulatory function that looks at safety, and we work very closely with MedSafe in a whole lot of different ways in terms of communication and sharing information and sharing reports with a view to translating findings into alerts, or perhaps even discussions at this Medicine Adverse Reaction Committee that we spoke about, or even bringing about changes in data sheets or prescriber advisories around drug injuries. So that's a very tied down system. For some of the reports that come through the centre, and again this was partly addressed earlier with some of the examples that Michael spoke about, and even in the last presentation, where we identify or you notify to us an adverse event that has resulted in some significant harm or represents a contraindication to that patient's future use of that medication, we have a unique system in New Zealand, which is an electronic medical warning system. It was established in the 1980s when New Zealand's first health computer was put together, and it still exists today. There are some issues with it, but it's still working and exists. So if you notify an event to us that is a contraindication to its future use or has resulted in significant morbidity, we will record an alert of what the drug was and what the adverse event was into this national system, so that when you turn up at a DHB, because currently that's pretty much the only entity that can access this thing with the exception of a few South Island general practices, that information is available on your admission. Now, in the old days, before the increasing use of electronic practice software in the hospitals, that alert when you turned up at the admission section of the hospital, those details were translated onto the front of the hospital folder or onto the prescribing sheet, so that at least you knew that you shouldn't prescribe this medication again. But of course, with our increasing use of electronic technology, this is now sucked into prescribing systems and the like. So this is one way in which already for a good number of years, in fact decades, New Zealand's been contributing to try and reduce error through re-exposure to medicines that we know are a problem for individual patients. So CALM has a home and has that entity and represents an infrastructural entity that many people know about in New Zealand, by the show of hands, at least in this audience, and there's regular contact. We get about 5,000 or 6,000 reports a year coming through our centre. Being a university environment, it's been possible to introduce other programs, and we have introduced a number of drug safety-related initiatives. And one of those was the medication error reporting program, which we started thinking about in 2007. That operates today, but it doesn't really have a legislative home in the same way that CALM does, but we're very grateful that the Health Quality and Safety Commission came into existence a couple of years ago, and that provided a really handy vehicle for us to feed those reports into a forum where they could be discussed and addressed with a view to bringing about positive actions to reduce harm through that avenue. So that's been quite good. So if we look at the flow of data coming through the centre, reports will be notified to the centre either directly to CALM because it's known to be an adverse drug reaction, or directly to the medication error reporting program. But that's not where it stops, because there are instances where reports that are notified to us as adverse drug reactions, on our evaluation and assessment of those reports, actually reflect an error. Why did this patient get this drug? Why was that dose so high? What about that interaction? All of those sort of issues are discussed and or considered. And when those reports come through, they are fed through the system into the medication error reporting program so that we can build up a national data set around those sorts of issues and complement that data set. So that's proved to be quite a valuable component of our system. So just to reinforce some of these issues that I've mentioned here. So we have this one portal for data coming in. We have an infrastructure that works. We're familiar with thinking about issues relating to safety. Obviously, the differences between evaluating a medication error and adverse drug reaction, there are nuances and differences in them, but it really has proved to be quite valuable. I've spoken about the synergy of these systems, and also I mentioned when I was talking about the fact that the university can put different programs together. Because we have that flexibility, over the years we've added other programs to CALM. So CALM was the first one there since '65. In 1977, some of you will remember the intensive medicine monitoring program, which was novel for its day. It's now no longer novel. There are other better ways of doing the data or doing those evaluations and analyses. So that was a program we added. 2009, we brought in the medication error reporting program, and in 2012-13, with the synthetic cannabinoid issue in New Zealand, we added a program to monitor psychoactive substances, which is still operating. We're looking to try and keep that rolling on. So it's been quite easy to add these programs, and it's using the common infrastructure, the common philosophy, the knowledge that from health professionals and even some of the public, that there's one place where you can report issues around the use of products, largely in a therapeutic sense, but we get reports to hair products and toothpaste and all sorts of things, which fine, we'll deal with that, but it's about a centre of vigilance. So we've heard about this global challenge, and certainly CALM has got or the Pharmacovigilance Centre has got a system going, but it's interesting to note that in 2013 the European Union made this decision that medication error is really an integral part of pharmacovigilance, and they changed the definition of pharmacovigilance, or actually the definition of an adverse drug reaction, to include medication error. So reflecting the thinking that, or the knowledge and the understanding that actually these things are inextricably intertwined very often. There are extremes of the spectrum, but there is an intertwined basis for it. There are many countries which operate these programs now, certainly in Europe anyway, independently, and we've certainly seen the example in Canada, and the US has also got one. The UK has had a system some years ago and still has one. And there's only one other country, to my knowledge, that has an integrated system in a similar way to we have, and that's Morocco, where they have the poison centre, the equivalent of CALM, and the medication error program altogether, and we actually work in reasonably close collaboration with them as well. So what about this medication error? For those of you who didn't put your hands up and didn't know about MERP, let me just tell you a little bit about it. So this program is really designed, or was designed and proposed and motivated to capture and collate medication error events that were occurring in primary care. So why do we choose primary care? Well, primary care is the area where pretty much most medicines are prescribed. And actually, if we think back to our system in New Zealand, most hospitals, DHBs, have got some form of incident evaluation system. They work to varying degrees of success, but they're there. But primary care's got zero. And so this was the motivation for the program, was to put something in primary care to fill that void and identify where those issues are arising. And of course, once you've got that, you can identify what the issues are, and essentially the issues are weaknesses in systems. If we can address what those issues are, we can begin to target areas and bring about improvements in harm, in reducing harm. I've illustrated in the other panel there the core principles of the EMP, and the core principles in our EMP program is that it's totally anonymous. Confidentiality is uppermost, well, confidentiality is uppermost in the CALM program as well, but you don't need to tell us who you are. In fact, some people perceive that to be a barrier, that you might not be inclined to tell us about something that's somewhat embarrassing. So we don't need to know who you are. But in the same way that Michael was talking about earlier today, some people do want to tell us who they are because they want us to get back in touch with them to find out more about those events. And we respect that. Any data that is provided to us in terms of named data as to who you are as a reporter is only kept for a short period of time. We've got a cut-off internally of 6 weeks. If we don't get back to you in 6 weeks, we don't know any more about who you are. So we try to stick with that. So, and a couple of the other principles are put in there about getting quality data and working through the system. So what are the advantages of the system that we've got in place here in New Zealand and the MERP? And this has been our experience and partly driven, or largely driven, our philosophy around the way it works and the way that it was designed. So the idea is, yes, to get reports from primary care, and really anywhere else, but that's the focus. We establish a database, a data set around it, and in the process of evaluating those reports and looking backwards into our data set, it provides us an opportunity to look at those contributing factors that have led to those events. In building our database and getting the data in, we've insisted on getting quality data, and one of the ways of getting quality data about the drug exposure has been the use of the New Zealand Universal List of Medicines. And those of you that use the NZULM will know that you get right down to the individual pack size and formulation. And that's critically important if we're looking at some of the issues around problems that arise around something peculiar to a particular pack, rather than just saying it was venlafaxine, for example. So that's been an important thing. We've been pretty insistent right from the very start, and this was really with the guidance of ISMP Canada about sticking with international terminology or taxonomy around how do we classify these adverse events. There are a number of home-built systems that I've become aware of here in New Zealand and in other places. And the problem with that is that although it makes sense to the person who's designed the system, in the end, when you're trying to compare data, it becomes pretty difficult. And so we've stuck with this, and this is the international direction, certainly partly or largely promoted by the Global Challenge now as well. So it really is an important framework to have and facilitates analysis. We've also built the system on the basis that we thought that, well, it's not just primary care. Ultimately, we would like to get a complete picture of what's going on in New Zealand, and recognizing that there are other places in this country where information, data about medication error events exist. And those come to mind are the medical defence unions, the pharmacy defence unions, the ACC, for example, a whole variety of different sources, the Poison Centre, for example. And so we've built our system on the basis that we can import that data into our system through electronic transfer. Sometimes there are issues in terms of the fields that are collected, and again about what taxonomy they've used, but the point is at least this is an attempt to try and pull that sort of data together. And in doing this, and in building our system, we've also been mindful of the fact that we don't want you to have to recap or re-enter the data. So as far as is possible in any of the systems, if we can avoid duplication because the data is already collected, we've harnessed that technology as far as possible. So, right, so just I've already spoken about some of these issues here. The MERP was thought about in 2007. We got some funding in 2009 to roll it out as a pilot project. in those days under the guise of the Quality Improvement Committee, which was the forerunner, I suppose, in many ways of the HQSC. And that was a proof of concept to show that it can work, and it actually did work. We got some useful data which was fed into the systems in New Zealand. And then, very fortunately, we got some further funding to roll it out as a national program, which we did, and that funding ran out at the middle of or towards the middle of this year. And we've now got some funding to keep us going until the middle of next year. So let's just talk a bit about the medication error program itself, and I'll just take you through how we work in our program. So starting out with reports, again, I made the point that we've tried to make this as simple as possible. Within a few minutes of using our online portal, we can get enough information in a structured format using drop-down lists to get the data that we need to populate our data set. The data comes in largely electronically through online reports that you as individuals, for example, might put in, and as I've mentioned earlier, batch data comes to us from a variety of different sources which we can import into our system. And it's not just a case of importing them. Each of those events, as they're imported, once we get them in, we go back and have a look at all of them, and they all get evaluated in their own way. So it doesn't just become a black box of data coming in. Right, and of course there are also paper reports that come in. If they happen to come into the centre directed to CALM or wherever, we recapture. Those are the ones, unfortunately, we have to recapture. So once the data is in the system, it's an opportunity for us to analyse those reports, either as individuals as they come in, as individual reports, or obviously the database collective provides an opportunity for aggregate analysis of those reports. And they then, this is just an example of, Michael's given some excellent individual examples, but just in the New Zealand flavour of things, this is what we've had over the years that we've been operating. So the top graphic is about event types, and the bottom graphic is outcomes. And you can see from the outcomes that there's some really significant events, including fatal events, that have occurred even here in New Zealand as a consequence of medication error. So we're interested in using this data, turning it into solutions, and so every month the medication error reporting program prepares a report for the HQSC, which is discussed at the expert advisory group, and in that report our data is discussed under a number of different categories in terms of seriousness, in terms of individual reports, in terms of patterns of observations, with a view to suggesting that these are issues, these are areas that we need to focus on, and providing guidance for particular actions which the HQSC, through its various avenues and channels, has turned into alerts in one form or another. Of course, not all of them can be addressed because there's a lot that comes through the centre, and of course the HQSC has got other priorities as well, but certainly the most important ones do get addressed. And so this becomes important for us to share the information. So yes, we share it with HQSC, but we're also mindful that this data should be shared more widely as well. Certainly the philosophy in the Pharmacovigilance Centre is that it's not a black hole of data in. Whether it's for adverse drug reactions or for MERP or for anything that we've done, the data is there for an important purpose. And we need to distribute that data, make it available for research and share it with other entities. And that's certainly what we do with the MERP data as well. So just some examples of how we've translated this data into value for the sector, bearing in mind that I have already said that we focus with the we work and focus on particular target issues with the HQSC, but beyond that as well, MERP has just very recently established a medication safety email network where people who are interested in this area can join and contribute, the champions in this area, share observations, trends, emerging issues, and just provide that forum to particularly focus on things. And it helps us also to go back perhaps and have a look at the data that we've got. If we missed something here, perhaps of anecdotal observations that you might have come up with on that network. If you're keen to be involved or want to know whether you're in the network, that's the email address. Get in touch with us and we'll be there. But we've also recently initiated a newsletter that goes out, and this is one of the first that has gone out. and the idea is that this will be distributed quite widely, and we're very grateful that other entities have picked this up as well and echoed some of these observations in other areas. There are other ones who have agreed to echo these observations in their own publications. And this is picking up on some of the smaller things, some of the practical observations that have come up, and again, it's about sharing the data. Also to illustrate that we do work with other agencies, and again, this is either on our own or together with HQSC, and here's an example of interaction with both MedSafe and the pharmaceutical industry, and this relates to a labeling issue. So here's the outer package, and this is ketamine, and it says 200 milligrams in 200 moles. But when you look at the individual vial, it says 100 milligrams per mole. That's a 2 ml vial. So there's confusion that's arisen around that, and of course that leads to the potential for errors. So working with everyone, the vial labels have been changed to be more consistent with drawing attention to the fact that this might not be 200 moles. Again, the formulary, the New Zealand formulary, has been valuable to us as well for echoing alerts that we've come up with and observations in this instance here about insulins. Another example here of working with the pharmacy software, and I'm not exactly sure whether this is Tanique or Lots, but certainly we worked with them to highlight the issue around the selection of different types of insulins, again, because there was confusion in terms of the drop-down lists that were very easy to make mistakes on, and this led to an improvement. And the last area that I want to focus on, just as an example, is the multi-incident analysis outputs that we've come across, and Michael again referred to this in his examples earlier on today, and this was pediatric oral liquid compounding, with a number of cases that we've identified with issues and problems arising from that, and this has led to a compounding advisory group that has been established that meets regularly to consider issues, give advice, and help to keep things focused in the right direction. So moving on, the current situation of the MERP is that, yes, we've got a program. It's easy to use, and it's provided useful data, and it's certainly, through those examples, been able to inform a number of national initiatives. But like with everything, all programs have got their issues and challenges, and for us, one of the significant challenges, as you will see from that example, is short-term funding. We've had a series of bits of money that keep us going along the way, and there's uncertainty about where we go. We certainly would like to have wider exposure at a national level. We already have a reasonable amount of exposure, but you can never do enough with any program that you're doing that is of a national nature. And perhaps one of the most significant constraints for us at the current time, and again this is a resource issue, is that we don't have the resources to grow it in any significant way or even address things. And you might not be aware of the fact, but the whole MERP operates on half an FTE, dealing with 600 reports a year, including all these reports to the committees and interactions with whoever. So I think, and I'm not directly involved in it, this is Desirée Kunac's work, this is a tremendous achievement for the very small investment that is made. So where are we going in the future? What do we think about the future? So certainly we believe that we've demonstrated the value of the system on the relatively small scale that it actually is. But we would like to extend it, certainly. We would like to see it further embedded in primary care. As I said, it started out in primary care. We can always do better. There are always pharmacy outlets and GPs who have yet to buy into the system, but certainly valuable. One of the requests that we've had pretty much over all the time, and certainly in recent time, is for larger organisation groups, the PHOs and the groups of pharmacies, to access their own data for their own local audit purposes. And we've been quite keen to do that, but again, it's a resource issue to build the software, to do all the packaging and whatever. So that's something we would very much like to be able to do, but it's a bit of a constraint. We would like to spread the MERP into other areas as well. So yes, the focus is primary care, but there are other areas too. And certainly we've had some feedback that suggests that some of the DHB-based systems are a little bit cumbersome to use, and we're suggesting, look, the MERP works, it's got a great taxonomy, and if there's some way that we can collaborate and work together, that'll be really, really great. and let's see how many other areas we can get involved in. I mentioned right at the start that the European Union has adopted medication error as or integrated medication error into the definition of pharmacovigilance, and that's something that I think we should be looking forward to trying to achieve here in New Zealand. Now, I don't know if all of you are aware of the fact, but some of you may be aware that the Medicines Act in New Zealand, which is now very old, dating back to the very early 80s, is being rewritten. And I understand not too long into the future, maybe going out for consultation in its draft form. And certainly we will be motivating for saying, well, think about extending MERP into the definition of pharmacovigilance. When you see this act, I encourage you all to perhaps think about echoing that as well. It'd be tremendously valuable and maybe give this a more formal home. So what are the next steps? We have established the motivation, and some of you, I don't know if any in this audience, have brought into a stakeholders meeting to consider where are we now, what's the future, how can we sustain this thing into the future. At the time that I put this image together, it was November, we got a meeting in mid-December, late-ish December, to have a stakeholders meeting where we will consider how we might do this. I would very much like to see that this is everyone's contribution, and if we can get a contribution from everyone through a governance group, where the governance group can actually inform and drive and influence the direction of the MERP to be of value to everyone, that would be a really, really great direction. So if you've got any thoughts and feedback on where we might go and how this might work and how we could keep it going, that would be really great. It'd be a tragedy to close it down, and that's what we might need to do if the funding runs out. And I should say, this is, I'm talking about MERP, I'm talking about CALM funding. There's some MARC people here, and I'm hoping CALM will continue into the future. This is separate from CALM. This is about MERP. I want to finish, just for the last minute or so, with a video. I hadn't planned to put a video in here, but when I came to the first presentation, there were all these videos going, and I thought, well, I better put something up. And I just fortuitously happened to have this video. It's about pharmacovigilance and aimed at consumers, but the message in the video is really about communication. And it's communication about adverse drug events, but it's also communication about medication safety issues. Next week's the Medication Safety Awareness Week, and so this is an apt video for that. It's a very catchy tune, and you'll be humming this on your way home in the bus or the car. So enjoy this, and thank you.
When you get an A, there's a pill you can take. But if it makes you unwell, remember that you need to tell. Take and tell. Take and tell. Side effects show that your doctor knows. Take and tell. When you take your meds, there might be side effects. Remember that if you get some, or even if you just get one, you gotta take and tell. Yeah, take and tell. That's what you gotta do. If side effects show, let your doctor know. Take and tell. When you take your meds, and note your side effects, that's pharmacovigilance. And you know that it makes a difference when it's